Good evening, everybody, and thank you for joining us on our Safe Schools webinar. What I might do, if it's okay with yourselves, is I'll take a moment to talk you through our Safe Schools programme so that you know a little bit more about it, and also just to say you're welcome and hello and hi, how are you? My name is Sarah O'Connor. I'm the CEO of the Asthma Society, and you're also joined by my colleague Ruth. Ruth is a clinical nurse specialist with extensive experience in respiratory and an absolute passion for asthma education. We're really privileged that Ruth works with us on our WhatsApp nurse service. If any of you have used that before, it will more often have been will have been Ruth who's been interacting with you. Ruth and another colleague of ours, Samantha, work on that service, and Ruth is really passionate and really interested in how to help people understand about asthma and how to make sure that people have really good asthma control. So what we're going to be doing is I'll take you through a little bit about the Safe Schools programme, just so you understand a bit more about it. Ruth is going to talk you through some of the basics about what is asthma, how to recognise if somebody's condition is deteriorating, what does good asthma control look like, and what to do in the event of somebody having an asthma attack. And then what we're going to do is we're going to take your questions. Now, we have 7 or 8 questions that have been submitted to us in advance, and as we go, if anything occurs to you that you think is important or that you need to know more about, feel free to use the chat Q&A function. And what I'll do is I'll monitor the questions as they're coming in, and then when we come to the Q&A session, I'll put those to Ruth where there's something appropriate for Ruth to speak about, or if there's something more to do with our work as an organisation, I can take them myself. And just to say, I suppose from the outset, you know, you're really welcome. Thank you so much for being here and for taking asthma seriously enough to be here on what is certainly just here where I am, an absolutely beautiful day, and certainly the nicest one I've seen so far today. So we really appreciate it. I can just see that we've had a question there from Kim, who's asking if it's too late to register. Absolutely not, Kim. You can go into the link that's already there. If you share that with your friend and get them to register, they'll be able to come straight through to us. So to take you through a little bit more about our Safe Schools programme, we've had what we've traditionally called our Asthma Friendly programme, Asthma Friendly Schools programme, for a number of years now. And I suppose that programme was really positive and really good in terms of helping teachers and children to know more about asthma. So it involved often a visit from a nurse, a specialist in asthma, a presentation from that nurse, you know, a classroom visit, a Q&A, and some guidance from that nurse about perhaps how a school could improve their asthma policy. And it also provided, you know, we had a really nice information pack for children and for adults and for children to bring home to their mum and dad, let's say. And the way that programme worked was that we had a bronze and silver and a gold level, and depending on how many different activities the school undertook, they could become a bronze, a silver or a gold level of asthma friendly school. And I think really what happened from our point of view is, since COVID has hit us, you know, we've had a very challenging fundraising situation, but we've also had a very challenging situation where the demands on our services have been really extreme, and we've been inundated with queries for help. And so we really had to think about everything we're doing very carefully and to decide, okay, what's important and what's really needed, and how can we make every programme we run as cutting edge and as focused as it can be to get really good results. And so one of the things we felt was that the Asthma Friendly Schools programme was really good, but we wondered if it needed really extra momentum to get it to really target and eliminate asthma deaths, particularly asthma deaths in children. So some of you may be aware our overarching mission is that we reduce asthma deaths and prevent asthma deaths and reduce those down to 0 in Ireland, and we want to do that by 2030. And I suppose a major point of concern and fear for us is worse than an asthma death, which are all terrible, but an asthma death in a child is absolutely devastating. We speak to family members, to parents, to friends of people who've experienced this, and to teachers, and it is really the outcome that we want to avoid above all else. And so when we looked at our Asthma Friendly Schools campaign through that lens, we felt that we could do more and that we could be more impactful with that work. And so the team, while as a maternity leave, sat down and really thought about what it should be that we're doing, and they came up with some really good ideas. So the new Asthma Safe Schools programme, it's all focused on how do we make sure that every school that comes in contact with that program is as safe as it can be. So we've been successful in getting funding from 4 different areas of the HSE. Those are called CHOs. We have funding for 39 schools to undertake that program at the moment. That's why you will have seen that there's a small little questionnaire when you're registering for the survey. For us, I think we feel that this program can be really impactful. So we want to say thank you so much for filling in those questions as you were registering, because we want to use that information to talk to potential funders to say, look, we really believe that this meets a need for teachers, for schools, for principals, and that we want, I suppose, to use your feedback and your thoughts to really make sure that we make the case for this particular funding. So the Asthma Safe Schools program works in that attendees will get a webinar like the one you're attending today. This is our pilot version, so if we're scratchy or itchy, we really appreciate you bearing with us. The second thing that successful participants in the program will get is a full day of what's called pre-hospital emergency care training, and that's delivered by, you know, essentially a first aid expert training company. It's an 8-hour training day, and that includes all aspects of first aid, but it particularly includes a section about administering a salbutamol inhaler in the event of an asthma emergency. And then the third step that we hope to include after that is for us to provide support to schools so that they can apply to register as a school that is entitled to have a salbutamol inhaler on the premises in the school, specifically in the event of an asthma emergency. So it's not Lucy's inhaler in her lunchbox for Lucy if she needs one. It's an asthma emergency inhaler available to any of you as teachers, principals or SMAs that you can use in the event of really needing one. So for us, I suppose this is part of our focus on asthma deaths. We really believe it can be impactful. Any of your thoughts and feedback from today, whether it's about the atrocious state of my hair, which you can be aware of the fact that I'm aware of, or whether it's hopefully something more meaningful in terms of whether you think this has been a helpful webinar or whether you think the program is needed and wanted. Any feedback and thoughts you have will be really welcome for us. And I suppose what we would hope to do then would be to pitch for funding to be able to run this again later on this year, and hopefully to scale it up and to have as many schools as possible participate. So thank you so much for your time this evening. As I mentioned, on such a lovely evening, we really appreciate it, because to us it says a little bit that this program is right and good and that you need it and it's urgent and important, and that feels very good to us. What I'll do so now is I'll kick over to Ruth. Ruth will give a presentation talking, as I mentioned, about some of the basics about asthma management, some of the basics about the different kinds of inhaler or medication that you might be familiar with in the classroom. She'll talk about how to recognise an asthma attack and what to do in the event of one happening. And as I mentioned, feel free to send any of those questions through on the Q&A or on the chat function. I'll be taking note of them as I go. And then we have a really good meaty amount of time for Ruth to take those questions, because we think that's as valuable to you as the presentation as well. So I'll kick over to you, Ruth, with no further ado. Thanks, Mil.
Okay, thank you, Sarah, and good evening, everybody. And like Sarah said, thank you for joining us on this lovely evening. Here I am here in Leitrim. The sun is shining at the moment, which is nice. So anyway, as Sarah said, I'm going to take you through kind of the basics of asthma management. What asthma is, about the different medicines we use actually to manage it, and a bit of chat about the 5-step rule and acute asthma management as well, which I think you're really interested in and will be very important for you. So I'm actually going to share my screen, and let's hope all this will work. And okay, I just need to start my slideshow here. Right. So, basically, I suppose the thing about some of these figures you're going to see now are actually quite startling, and don't be a bit kind of alarmed about them, but they are startling in terms of asthma stats in Ireland. So again, we roughly say about 890,000 people actually have had asthma symptoms at some stage of their life. Now remember that asthma affects people right from the age of 2 and even a little bit younger, but usually it's diagnosed from the age of 2 upwards. You can be diagnosed with asthma at any age in your lifetime. I've diagnosed people up in their 50s and 60s and 70s with it. So it's not something that kind of children just get, but just to bear that in mind. So about 890,000 people have had some sort of asthma symptoms at some stage in their life. At the moment in Ireland, there are 380,000 people with asthma in Ireland. So a lot of that, and about, you know, on quite a few of them obviously are children. Now the Asthma in children can be tricky to diagnose. It's also very prevalent. About 1 in 10 children have it. So if you have a classroom of 30 children, so, at least, 3 of them are going to have asthma, maybe even more depending on where you're living. So sometimes in urban areas, it may be more prevalent than maybe in rural areas, and vice versa, that can happen as well. But roughly 1 in 10 children have it. Children can go out of it. Usually if it's diagnosed kind of under the age of 6, a lot of those kids, about 80% of them can grow out of it, but it can recur in 50% of them. So even though they're growing out of their asthma at 6, 7, 8 or that, and they get off their inhalers, it can actually come back again, as they get older, maybe as they go to take part in sport or for whatever reason. Some people, even when they move from Dublin to the country or vice versa, that can be a problem as well. But the few starting things here, there's 472 million spent on asthma in Ireland every year. That equates to €1,242 per person. The other one that's very startling is that every 4 minutes somebody actually will arrive in ED with asthma symptoms. Okay, that's quite alarming. And then of course 1 person every 6 days dies with asthma. I suppose one of the things I really want to get across here is that there's this whole concept out there, and this is one that concerns me greatly, is the whole concept of so-called mild asthma. There is no such thing as mild asthma. You either have asthma or you don't have it. And regardless of how severe your asthma is, you have to take it seriously. And that's one of the things that came through on our recent survey when we surveyed a lot of over 600 asthma patients with Asthma Awareness Week. They felt that the public in general do not take asthma seriously, and that's a major concern. But it is, and a lot of people, as we say, 1 person dies every 6 days. These are not people that actually have severe asthma that are actually dying. They're actually people that have so-called mild asthma or moderate asthma. So I know all the experts now are actually questioning the whole concept of mild asthma, whether there is such a thing or not. I would argue there isn't. You either have asthma or you haven't, and it has to be taken seriously. So the basics then, what is asthma? So asthma is a common condition that causes inflammation of the airways. Inflammation, what's inflammation? Inflammation is swelling and redness in the airways. The airways are the small tubes that carry the air in and out of the lungs. And remember that asthma actually starts from your nose. It's not just a lung condition, it actually starts up on your nose and goes right the way. It affects the whole area from the nose right down to the bottom of the lungs, to the tiny air sacs in the lungs. It causes the airways to become oversensitive and react to things that wouldn't normally cause a problem, such as cold air and dust. And there's a multitude of actually trigger factors, and we'll go through them later as to what could potentially trigger asthma. And remember as well that not everything that's on this list will actually trigger asthma in everybody, and sometimes it might only be 2 or 3 things. So again, that's some important part asthma management, that we actually sit down and talk to people and try and figure out what the trigger factors might be. But the dust is obviously one of the most common ones, and cold air has been a huge trigger this year. So when you look at these airways then, so over here on the left, you have a normal, healthy looking airway. So air is getting in and out there, no bother. So you can see these little muscles here on the outside of the airway. They're all nice and relaxed, and they're not squeezing in the airway. And up here you have got the air sac at the end. So again, air is moving freely in and out there. So everything's nice and normal looking. So this is an asthma airway. And this is even in somebody that's actually well controlled. Their airways will look like this. It's not a kind of somebody that's actually sitting there wheezing in front of you. This is actually what a normal airway will look like in somebody that actually has asthma. So here you can see that the lumen, or the center of the airway, is quite tight in that. And that's because this whole airway has become swollen and red as a result of inhaling a trigger factor. And then when somebody actually has an acute asthma attack, what happens is these whole muscles here go into spasm on the outside, which causes the whole kind of tightening up of the airway. Also in here, this swells even more. So therefore, the air will get in all right, but when you try to breathe out, then the actual airway is swollen, and then you hear this wheezing. So it's always whenever somebody is actually breathing out, that's when you hear the wheeze. It's not when they're breathing in. That's a different condition altogether. So these are just the different, what's going on in the airways, kind of just a pictorial thing. So as you can see here, the air is getting trapped down here, because you can see the alveoli is that bit bigger than this one here. I always describe these as like being a bunch of grapes. That's what they're like. So the air gets trapped in there. So the person actually, as I say, when they try to breathe out, so that you can imagine this person is actually breathing in loads of air, all right, but it's getting trapped in there. And then when they try to breathe it out, they can't, because it's trying to squeeze out through this little tight, small airway. So that's the way that it actually works. So when you look at the 4 different symptoms of asthma, you can understand them then from this. So when somebody complains of, and particularly in a child, they might complain of a sore tummy. because that's how they describe chest pain. So again, if they do that, it may be related to their asthma, just to bear that in mind. But that's because all these little airways are tightening up because the muscles are going into spasm. So it's similar to having a cramp in your leg. So everything just tightens up. And the wheeze comes from, as I said, the air trying to get out through this little narrow airway. The cough happens as a result of the airway, the little nerve endings in the airway get all twitchy. So you can imagine that in your nose, as you all know, you have little hairs. So these hairs are actually in your airways right down to your lungs. So those got all irritated and angry as well and trigger this whole cough thing. So the cough that kids get with their asthma, it's a constant dry bark and hack and cough that they can't kind of give a good cough and stop coughing. No, it's there, it's irritating the whole time. So this cough,
if it's okay with you, do you mind if I just, one of the questions that's come in there is somebody's queried if we're going to send the slides on afterwards. So just to confirm, we actually have a full asthma pack with a whole list of resources, links, videos, posters, that kind of stuff that we've prepared as part of the Asthma Safe School program. I should have mentioned that's actually part of the program. We will be sending that to all participants in the webinar this evening, and we will actually include this PowerPoint in it so that you have access to this afterwards. So sorry to interrupt, Ruth, I just wanted to make sure that somebody wasn't scribbling furiously there, that they can actually sit and listen and absorb what you're saying as opposed to trying to take it all down at the same time.
No worries. Okay, so the cough, this cough, as I said, it is really irritating. It won't go away. It can occur at night. In fact, it's very common with the asthma symptoms that they do occur at night, and particularly when a child's asthma is not well controlled. That's when it'll actually disturb their sleep. If they're not sleeping at night. It can occur during exercise, obviously. The other one to remember about the nighttime cough, it actually can be an early morning cough, either around, the way kids often wake up at 5 or 6 o'clock in the morning. That is considered a nighttime cough. So again, if a child is telling that they were awake all night coughing, well, they need to be going to the GP and getting an asthma review, because that's not a good sign at all. It indicates that their asthma is not well controlled. Shortness of breath, then again, is another symptom. And again, you can just imagine that air trying to be squeezed out through them little narrow air tubes, that's going to cause shortness of breath as well as wheeze. So the wheeze, then we describe it as a whistling sound that occurs whenever the child is breathing out. And the chest tightness then, in younger children, particularly children under 6, they might complain of a tummy ache, because sometimes they might be able to differentiate between or tell you that their chest is different to their tummy. So again, it's just another one to bear in mind. But some kids, obviously, particularly the older ones, they'll be well able to tell you that their chest feels tight. So again, this chest tightness symptom was never really included up until recent years. So again, the other thing about asthma as well is that you don't have to have all 4 symptoms to have asthma. You can even have 2 of those 4 symptoms and still get a diagnosis of asthma. So not every child is actually going to complain of all 4 symptoms. So just to bear that in mind, just because they're not sitting there in front of you with all of these 4 symptoms, that doesn't mean that they don't have asthma. A lot of children, cough is probably one of the most common ones, and wheezing, they're the 2 most common ones actually you'll see in children, but they can actually complain of not being able to get their breath also as well. So the different causes, then, we really don't know what actually causes asthma as such, what the actual, real cause of it is. But we do know that there is a genetic tendency. So generally, if you have a first-degree relative, either a mother, father, brother or sister, that has asthma, you're at higher risk of developing asthma yourself. If the onset is usually in childhood, but as I said, you can develop asthma at any age of your life. The climate usually has an impact on it as well, and particularly the Irish climate probably is very conducive to asthma because of the whole dampness and the environmental issues. It is linked also to allergies and allergic diseases. So, for example, if a child actually has eczema or hay fever, they're the same 2 things. With eczema, when your skin is itchy and red looking, that's the kind of itchy and redness that's actually going on in your airways as well. So they're actually more at risk of actually having an asthma diagnosis. So I'm particularly with hay fever as well, because 85% of people with asthma will have hay fever. And again, people that actually develop hay fever, or children even that develop pure hay fever on its own, they will actually go on more than likely to develop asthma at a later stage. So again, the 2 of them are actually, the 3 conditions actually are very closely linked. Our modern lifestyles, unfortunately, don't help things either. We're living in airtight houses, so air isn't circulating, ventilation can't be great. We're all in double and triple glazed houses. That has a huge impact also on asthma diagnosis. And again, because environmental and air pollution is such a problem, that has a huge impact also. And we all know, and I've heard of plenty of people saying to me that, particularly at school drop-offs and school times of the day, and there's loads of traffic around, that can be particularly problematic for children as well, and they're leaving school and all the cars they're picking their kids up, and you know, there's a lot of smoky stuff going around, so that can be a problem. There is an increased risk. So if a parent a mom has actually smoked during her pregnancy, that actually increases the child's risk of developing asthma also. Obesity, unfortunately, is on the increase. It's been increasing over the last number of years. It will continue to increase more than likely, but definitely, and we're seeing more obesity in children than ever before for a number of reasons. So again, I know that does actually contribute towards an asthma diagnosis also. Viral respiratory infections. This is a kind of a really common one, and this is the one where it's tricky in children. You know, when you're diagnosing asthma in children, it's actually quite tricky, because a lot of children will actually get, as we all know, they all get viral respiratory infections come September time. We all know the coughs and the colds start. The next thing, then they're wheezing. But remember, you can actually get wheeze with a viral respiratory infection anyway. That's not necessarily asthma, and that's where the difficulty lies. Do we diagnose this child with asthma or not? And that's why it's so important. And I know it can be frustrating sometimes when the parent comes in with the inhalers to you, and maybe the child has not yet been diagnosed with asthma. But what we do is, the reason why they're on inhalers, we still have to treat them as if they have asthma, because it wouldn't be good, because if we don't treat that redness in the airways, you know, you're going to run into problems later on. So, but however, we do actually kind of don't initially diagnose asthma in children, just because the first time they actually present to us with wheezing or coughing or any of the symptoms. So we kind of do watch it over a period of time. And then obviously the family history, as I said to you earlier, then about the first degree relatives that are important in terms of, so again, whenever we're making a diagnosis, we need to take a really good family history as well. So these are the different asthma triggers. So things that actually can set your asthma off. So obviously smoking, and maybe in older children and teenagers, we see this as being a problem. But passive smoking in younger children is huge. And again, parents often say to me, well, actually, I go outside to smoke. I said, that's not good enough, I'm afraid, because when you come back in from smoking outside, that smoke is still on your clothes and on your breath for 4 hours after you have a cigarette. So it's really important, actually, you try and quit smoking, and we try and encourage parents to stop smoking and give them all the support they need to do that. Animals then is another one. So cats, dogs, and horses. Horses in particular are really problematic for a lot of children. But again, not every child is going to have a problem with all the dogs and the cats, but sometimes it can often, be to get a new dog, and the next thing you hear, then the child is actually getting asthma symptoms. So it may be linked. But again, there are things we can do actually to see if the child actually does have a problem with dogs. There are different blood tests we can do to see if there is any issue with dogs. Because again, I know lots of people with asthma that don't actually have a problem with dogs. Again, if somebody is, a child wants a dog for a gift, or, as a gift or whatever, and as kids do, they all want their pets. So we would advise them actually to go and get a short-haired dog or a Bichon Frise. They're the ones, actually, they're the lower allergy dogs, is the ones we would recommend. But any dog, once they're short-haired, is better than having a really hairy dog. And obviously try and house them outside if you can, or in kennels outside, rather than have them in the house up on furniture and in beds. And that, definitely dogs and beds are a no-no. The other thing you have to remember is cats. Cats actually are problematic, and it's not really the fluff on them is the problem. It's actually the saliva in the cat is the problem, because the way cats lick themselves to keep themselves clean all the time. But that saliva actually is where the main trigger is. And again, not every child is going to have a problem with cats either. So sometimes it is a matter of trial and error with them. And I say horses are a problem. So kids that do horse riding as a hobby, that can be a problem. But again, there's ways we can get around that, in terms of maybe using some Vaseline in the nose when they go horse riding, and making sure they have their inhaler with them, and all that sort of thing. So there is ways around it. Exercise then is a big trigger. And I'm talking exercise, I'm kind of talking physical activity. I'm not talking going out and running for kilometers in the end or anything like that, but even just out running in the playground might actually trigger asthma in some, and particularly if it's actually a very cold day, if they're out. And there are ways around that with managing the cold air, which we'll chat about. Colds and flus, as I said earlier, the viruses are always problematic, and we do recommend actually that any child that has that's on, certainly the more stronger of the preventer inhalers, definitely should be getting the flu injection every year to kind of help protect against that.
If it's okay with you, I actually have 2 questions here from people specifically about triggers. Are you okay if I just put them to you now, because it might be useful while we're actually talking through this section? Is that all right?
Okay, that's fine.
Perfect. Sorry. One of those is, can a child being out in the rain trigger asthma symptoms? And the second one is, are itchy eyes and sneezing also symptoms of asthma when around animals specifically?
Okay. Yeah, getting wet in the rain isn't going to trigger asthma, but I suppose like everything else, I suppose it's possibly going to trigger a virus. Maybe if they, if they get wet and they don't change their clothes, etc. But no, I mean, out in the rain really shouldn't. But do remember, the other thing to remember about weather is that the thunderstorms in particular, I mean, a lot of asthma patients actually tell me, actually, I know that I'm going to have, there's thunder coming because my asthma is getting worse. So just to bear that in mind, that weather can have a huge impact on their asthma, and particularly the cold air, as I said, and using a snood over the mouth and nose actually will help to warm the air going into the airways. So if you know of a child that actually, when they're outside at playtime or whatever, and the cold air is a problem, just get them to pull a snood over their mouth and nose, and that will actually help to eliminate some of the symptoms there. Now, Sarah, I've forgotten the second question. What was it?
The out in the rain, and the second question was about about, are itchy eyes and sneezing also symptoms of asthma when around animals?
Yes, it more than likely is going to be, around the animal. It would definitely will be. It's not so much the symptom of asthma, but it's more the symptom of an allergy to that animal, which can in turn trigger their asthma. Okay, so again, if they're going to be around the animal, and it is causing a problem, and see, it could be the house dust mite that's actually in the dander of the animal that could be triggering this symptom either. So again, I suppose putting a bit of Vaseline on the mouth and nose, actually, or on the nose rather, will actually help to stop them inhaling the actual dust, if you like, to try and trigger, and that eventually could actually trigger their asthma. So yes, it's more an allergy problem than. But in turn, it can actually trigger their asthma. It's similar to hay fever. Okay, so if you have, and we're actually talking about pollen down here, which is currently very topical at the moment, like that too, using like wraparound sunglasses, putting Vaseline in the mouth and over the nose can help with that. Other wee tips is not to be outside when the pollen counts are really high. If you're going to have if a child wants to go out to roam around and play, try and get them out maybe earlier in the morning. Not having the windows open on their bedroom all day long, maybe just early in the morning as well, and then close them later on in the day. Again, when their clothes come in off the line, give them a good shake, and that will help to eliminate pollens. But that will be, those symptoms of sneezing and itchy eyes and itchy nose will be related to also to pollens, and which are grass and trees and flowers as well. Grass pollen actually has crept up now in the last number of days. Tree pollens have been very prevalent over the last couple of months since March. There are different and there's more and more things coming on now that actually can help to manage these in terms of medications and that as well. So it's about that are becoming more available as well, and particularly for the house dust mite, there's a new treatment for that out as well that can be useful. Dust, how do you get rid of dust? You can't get rid of dust. It's impossible to get rid of it. But things like, damp dusting definitely can help, rather than using sprays and smelly things that will actually help to, that could increase asthma symptoms. So we always will recommend that you damp dust rather than, so if you do that, then you're not going to be spreading dust all around the place. Emotions. The other thing, sorry about the dust, going back to that, the dust mite actually hates the cold weather. Sorry, hates the warm. Get this right yet. The dust mite actually hates the cold. So if you actually open the windows, it'll actually help to keep the dust levels down a wee bit. It does help, and it doesn't thrive in those cold. Now I know you all have your windows open at the moment due to COVID, so that it probably is helping the dust to a certain degree. But again, it's something to remember that maybe in the home and that windows are kept open, apart from when pollen counts are high later on in the day. So it's a hard act juggling all these things as well. So it's feelings then. So emotions, any sort of, so I've heard loads of people actually, when they take a fit of laughing, they'll actually start wheezing. And then obviously if a child gets upset, that actually can trigger symptoms as well. Medicines, there are certain medicines such as like the likes of ibuprofen that actually can trigger asthma in a small group of children. That actually can be a problem. So again, paracetamol is always the first line of treatment for pain relief or temperature management. So we don't actually recommend that you use ibuprofen as a first line there. Cleaning products then, this is always a wee bit controversial. Again, anything that's, and again, it's going back to the damp dusting. But however, there are a lot of these cleaning products, some of them can be quite pungent in terms of a lot of, they're quite the fumes of them can be quite strong. That actually can trigger asthma in a lot of patients as well. So that's another one to bear in mind. So again, if those products have to be used, and you probably are using them quite a bit at the moment, so I would be inclined to make sure your rooms are well ventilated whenever you're using these. And definitely and maybe not to be using them whenever there's children around either. And if for yourselves, even if any of you have asthma and you have to be using cleaning products, wear a mask even inside in your clinics. That will actually help with those, with the strong smells as well.
Ruth, I know that Anne and Catherine had actually asked us about those in advance because they were concerned that the additional cleaning products being used in the school, to prevent COVID or to prevent the transmission of COVID were actually possibly exacerbating symptoms. So I suppose your answer to that is, yes, it's quite possible there are, that they would cause some children to experience symptoms, but that I suppose those preventative measures are what you'd suggest to do to counteract that. Is that right?
Yeah, exactly. Yeah, make sure the rooms are well ventilated whenever you're cleaning. And as I say, even for yourselves, as I say, just pop on a mask, and maybe, obviously I'm sure you're doing your cleaning when the kids are out on their breaks and that sort of thing, not to be doing it whenever they're in the classroom if you can at all possible. And maybe even using wipes. Wipes wouldn't just be as bad, even though I know they're not very environmentally friendly, but at least they wouldn't just be as bad as a spray. That's another option as well. So sprays, as I say here, they're lethal, and we all know, we're familiar with the teenagers kind of doing the spraying of the deodorant in a small confined space. We're all familiar with that and have an experience of it, but that's a huge trigger for asthma. So again, some of those sprays aren't great either, so I would try and use an alternative to using any sort of a spray. Mildews and molds, then that's more obviously to do with dampness, and hopefully that's not a problem in your classrooms. But again, it can be, and molds in particular around September time. Usually, as I say, it's pollens, grasses and that sort of thing up until September, and then the molds kick in then. That can be problematic for some people. Foods and drinks is another trigger. This is a very controversial one and a very tricky one, to be honest. And usually, now, in all my years, and I'm looking after people with asthma for the last 28 years, and I've never seen actually a person, adult or child, with asthma that actually is related to their food or their drinks. So again, if parents tell me that, oh, I think it's definitely milk that's causing this, so what we advise is they cut it out for 3 weeks and then reintroduce it and see what happens. And generally, as I say, everybody will tell me, no, there's no difference whether he's on milk or off milk. So again, I know there's genuine food allergy out. That is a totally different situation, and compared to not with asthma, but in relation to asthma and food and drinks, there rarely does it be a problem. The only times it can be a problem is that if a child is actually eating enough of preservatives and that sort of thing, and that can be a problem. The colorings and the E's and all those sort of things, they can be problematic. So obviously we're not obviously telling people to be eating loads of processed food, so just try and eat natural and fresh as much as you can, which we all should be doing anyway. And then you have the weather, and this is Ireland. We'll be here all day talking about the weather in Ireland, but again, the cold air is a big trigger, and particularly there during particularly April was really cold, and even May wasn't much better, and it has been a problem. So again, covering the mouth and nose with a snoot when you're going outside for the first 10 or 15 minutes that you're outside, that actually can help to warm the air going into the airways, and then that actually can reduce asthma symptoms then also. And I said, don't forget the thunderstorms. So, if somebody's telling you that their asthma is getting worse and there's thunder on the way, they're not telling you a lie. So certain jobs, and obviously this is more for older teenagers and that, but again, there are certain jobs actually that can be problematic for people with asthma. And again, maybe if a parent is actually working in a job and they could be bringing home, for example, I'll just use this as an example now, horses, if they're working if a parent is actually working in stables and that sort of thing, and they bring home their work clothes, that actually can trigger asthma in a child, if the child is actually rubbing or hugging the parent and that sort of thing. So I mean, there are things that actually can trigger it. So they're the main ones. As I said, they're the majority. The other one that we know is obesity, as I said earlier. The other one then is reflux disease, stomach reflux. That can be a problem for some children, yes, and it can trigger asthma in some children. And the other one then, the final one then, is hormones, and particularly with the older girls, kind of at that 11, 12 years of age, they actually can develop asthma never having had it before. There's 3 times females can develop asthma in their lifetime. One is at 12, 13 at puberty, one is when they become pregnant, and one when they become menopausal. And they may never have had asthma before, and you can develop it. So they are things just to bear in mind. So if a child of 11 or 12 is actually suddenly becoming wheezy, well, maybe we need to investigate that further. They could be developing asthma. and particularly if there's a family history along the way as well. So we'll be thinking maybe. So again, the diagnosis of asthma, and particularly in younger children, is extremely difficult and extremely tricky. And there is no single test to diagnose it. We do a number of things. So one of them will be, we usually look at the family history. We look at the pattern of their symptoms, particularly asking about nighttime symptoms, exercise symptoms. Again, we will examine their chest. However, sometimes when we listen into a child's chest, and if they're not wheezing, you very well may hear nothing. It could be a perfectly normal chest examination. We do a peak flow test, where they blow into this little machine, and that can actually be very useful as well. And of course, lung function testing in older children can be very useful, which actually currently during COVID, that's not been done. And very often, particularly in younger children, the way we diagnose asthma is looking at the family history, the pattern of symptoms, and then put them on a trial of asthma treatment and see how they actually respond to it. And that trial of treatment could be for 6 weeks, and then take them off it and see how they're getting on. Usually if symptoms recur, well, then that's telling us that's more than likely asthma. So sometimes this is never going to be diagnosed on one visit to the GP. That's the big thing, message I want to get across there. It is kind of a pattern we follow, and it does take time. And it can take maybe 3-6 months, maybe even longer before we get a diagnosis as well. So we have to be patient about it. So is there a cure? Asthma cannot be cured, but it can be controlled with appropriate medication management. And we'll go through the different treatments now shortly. And the most important thing is that people with asthma should be able to live a healthy and active life with minimal symptoms. And that's the aim of our actual treatment, that our management, that, you know, kids are able to do what they want to do, play sport like everybody else. And we know there's plenty of athletes out there that are kind of high performance athletes that have done very well, that have asthma. And so what we're looking at for good asthma control, then we're looking at being able to be active without actually having any asthma symptoms. Sleeping through the night is really important without having any asthma symptoms. Not having to rely on a reliever inhaler. So the blue inhaler, which I'm sure you're all familiar with, that is the most common inhaler. Everybody talks about the blue inhaler, but unfortunately it's not the most important one, but it's the one that they'd always talk about. And then that there's no disruption then from their daily life. So they're able to do everything else that their peers are doing. And one of the symptoms actually, which I didn't mention earlier on, was about a younger child, particularly the younger ones, if they're looking to be carried all the time, and if they're looking to be kind of not keeping up with their peers, that's often a sign that they could have asthma, because they should be able to keep up with their peers for whatever reason. They're getting short of breath, or they're getting wheezy, and they're not able to keep up running around and that. So it's often an indicator as well. So it's often a question I would ask, you know, is your daughter doing the same as your other children, or anybody else in the classroom as well that's her age? Is she doing the same as everybody else? So achieving good asthma control, then we should be looking at avoiding triggers. So we spend a lot of time actually talking to parents and children about how they actually manage their triggers. Again, sometimes when a child comes into me, sometimes they actually mightn't know what the triggers are. The parent mightn't even know what the triggers are. So very often we have to send them away with a diary and say, look, see what actually is triggering this child's asthma. A lot of the time they're able to tell you straight up, it's this one, it's that one. But it can take a bit of time to find out what the triggers are. And again, triggers can develop over time as well. So whatever was triggering her asthma this year, it could be something else next year. So it's constantly changing as well. But again, they do get to know kind of quite quickly what actually is triggering them and how to actually manage them. Ensuring that they have good inhaler technique. This is so important, that the child is actually using their inhaler correctly. And if they're using it, this little fella down here, as you can see, has a spacer device, and we'll be talking about how you actually can use that later. But again, if they're using these kind of traditional kind of squirty inhalers, and most children up to the age of 7 will actually be using one of these and a spacer. Children over the age of 7 more than likely will be hopefully be moved on to using an actual dry powder inhaler where they don't actually need to use one of these. So again, spacer technique is really important, and you can see how to do the spacer, learn how to use the spacers on our Asthma Society website in the inhaler technique section. There are some videos there that you can learn how to do those, and we'll show you a video later too about how for an acute asthma attack, how you actually can use a spacer as well. So the other thing then is to remember is to take medication as prescribed. So whatever way the GP or the consultant has prescribed the medication, it should be taken. Never ignore asthma symptoms. You know, if a child is telling you they're wheezy, they're not making it up. And remember then that wheeze is not always present. So again, as I say, not all children will actually have wheezing, but if you hear that constant coughing and you just, you know, you maybe say to a child, will you just give a good cough there and get rid of that? But they can't, because it's constantly there, because you have that twitchiness and you have the redness in the airways. It's actually causing that constant coughing all the time. So this is what the gold standard is. This is what we're aiming for actually managing children with asthma. So the signs then of uncontrolled asthma, and I've said a few of these as I've been going along, but we'll go over them again. So obviously if the child is wheezing, if there's shortness of breath from walking or climbing stairs, if they're waking up at night, and this is a huge big alarm sign. You know, this is actually, even if a child wakes up one night this week with their asthma, that actually can be a warning for an acute attack that's going to happen 2 or 3 weeks down the road. So just to bear that in mind. So it is actually really important, you know, that we do ask that question if children are actually waking up or getting short of breath during the night. If a child is using their relief inhaler more than twice a week, this is if they're over the age of 6. And if they're using a relief inhaler and they're under the age of 6, if they're using it more than once a week under the age of 6, that's a sign also that their asthma is not controlled. So again, children over the age of 6, it's twice a week. Under the age of 6, it's once a week. So if they're using that blue inhaler more than that, then that indicates their asthma is not controlled and they need to go to the GP, or certainly ring the GP and get you know, a kind of a review of the asthma done, because they may need to get their medication increased. And this can be around September time as well, because again, when kids go back to school after the summer, because maybe, you know, they've been out of the school environment, they're out and about, and then they're back in the classroom again, this can be a hugely problematic time for children whenever they go back to school. So a lot of children do often end up increasing their medications, you know, when they go back in September. And if their asthma is interfering with their daily life, this is actually obviously, you know, as I said, this should not be happening. And if it is, then they need to be chatting to their GP about that. So let's have a chat now about the asthma management. So this is what a peak flow meter. I remember I said to you earlier, when we're diagnosing asthma, we use this as a peak flow meter. So the child actually puts this into the mouth, and once they're over the age of 5, they actually can use this quite well. So they take a big breath in and pop that into their mouth, and then they blast out really hard and fast, and this little red thing shoots away up here. So depending on the age of the child and depending on their height, this will actually tell us what their lungs should be doing. This is how we actually monitor their asthma. So while asthma cannot be cured, proper management can help control the disease and enable people to enjoy a good quality of life. And most people with asthma will require regular medication in order to control their underlying inflammation and stay well. And good management usually involves both medication and some lifestyle interventions. So this regular medication here, we do call this controller medication. And this is the most important inhaler of them all. Okay, so these inhalers tend to be brown in colour. They tend to be, I always call them the autumnal colour. So they can be brown, they can be reddish, they can be orangey. So again, that's the colours of them. They're not the blue inhaler, it's these colour of inhalers. So you can see them down here. That's one there, and we forget that one. See, there are different ones there. So any of those autumnal colours, they're actually, as I said, the controller medication. This generally is taken twice a day. And it does take a bit of time for it to build up in the airways. It doesn't kind of work straight away. It's not like the blue inhaler. When you take it, it works in 5 to 10 minutes. This can take up to 5 days for some of the inhalers. Some of them actually can take up to 2 weeks to work. So when a child actually starts this medication, it doesn't work straight away. And we do have to educate the parents about this, that, you know, it will take this length of time for it to work. So you have to stick with it. And when it does work, you'll know about it. The child will be a new child. So again, as I say, it takes a period of time for it to build up. Typically required to be taken daily, usually in the morning and evening, and even when the patient is feeling well. And this is the thing we need, the message that we need to get out there is that, you know, regardless of everything's 100%, the child is very well, has had no attacks for months on end, and you know, but they still need to take their prevention medicine or their controller medication, even though everything is very well. And again, I suppose over the years working with children that have had asthma, they're very good at during school terms. Parents and children are brilliant at actually controlling their medication and taking it twice a day, every day. But once the summer holidays kick in, it's amazing how many children don't actually take their medication because they're out of a routine. So it's all about routine. And then you're all familiar then with the blue medications, so the reliever or the rescue medication. So this is used to treat asthma symptoms, so or treat an asthma attack. So only whenever the child actually gets symptoms should they be using this inhaler. It can be taken immediately when symptoms appear. It works within a few minutes, within 5 to 10 minutes, it will have worked and relieved the child if they're actually wheezy or if they're coughing a lot. The regular medication, it relaxes the muscles around the airways. and the narrowed airways, and it'll open things up again. But remember, it does not get rid of that redness into the airways. That's where the controller comes in. The controller one actually gets rid of the redness in the airways and prevents the symptoms coming on in the first place. And then whenever you take the blue inhaler, then it opens the airways, making it easier for the child to breathe. So that's your blue inhaler. Again, all these medications, this particular one here, should be used with a spacer. Okay, and this is what a spacer looks like. There's a few of these different ones on the market. The aero chambers up here, this one here with the mask on, that's a child's one. This is a baby spacer, a baby inhaler, and then this is the volumatic, which is the bigger one. Most children actually probably will have one of these. They are that bit smaller and they're easier to carry around as well. This one here is probably a wee bit big for a lot of children, but however, it is commonly used and it's on the medical card, so that's why one of the reasons it's commonly used. So it's a plastic tube with a mouthpiece at one end, or a mask, whichever. This one here actually comes with a mouthpiece as well for older children as well, so they don't have to use a mask. So you have the mouthpiece at one end of it, and as I said, the inhaler sits into the other end. So the spacer makes it easy to use the inhaler and increase the amount of medication that gets into the lungs. So the spacers then, as I say, using these inhalers, to come back there to that, this particular one here, if you use that directly into your mouth, you're actually wasting a lot of medicine and wasting a lot of time, because none of that medication, literally none of it, gets into the airways. And you have to have perfect technique, and to have a perfect inhaler technique with these inhalers is actually very difficult. So to help that, then the spacers actually will make a big difference. So they will actually get the medication down into the lungs, and the child is much, they have more control over the breathing with the spacer, so they're well able to use it. So everyone with asthma should have a spacer, and with their blue inhaler in particular. Other medications then, we're talking here about, there are some medications called combination inhalers, which you may start seeing these a little bit more in the classrooms now, because of the the guidelines have changed a wee bit for managing asthma. So it's usually it's a white inhaler with a red bottom on it. You may start seeing that a bit more with some children, because they're going to be using it maybe as the reliever as well. But no, the majority things, most of these combination inhalers are going to be left at home, because they're twice a day medications, and the child might not be bringing them to school with them. The one that they're going to bring to school is the blue inhaler, to be fair. Then you have the oral steroid tablets. These are the ones they will take, and again, you probably won't be seeing these in school, because the children need these. They're too sick to be in school, to be honest. But again, they are there. They're only really used for acute exacerbations or acute asthma attacks as well. With medications, then obviously you always take them as prescribed. If you need your reliever inhaler more than twice a week, see a GP, and always have the reliever inhaler in hand at all times, and ask your healthcare professional to check the inhaler technique at every visit. That's so important to have that checked, to make sure the child is actually using their inhaler correctly. So some non-medical interventions then, so things like monitoring symptoms, using an asthma action plan, using a peak flow meter. Again, not all children will have one of these, but some of them might have. Avoiding triggers, as I said earlier, we went through them earlier. So again, that's the big one, to try and avoid them. Some triggers are not avoidable at all. You can't avoid them. Like the weather, you can't actually do an awful lot about that, but you can actually help with, as I say, using the snood and that. Good inhaler technique, as I say, is essential. Keeping the asthma action plan up to date is really important. So if a child's medication gets changed, they need to have their asthma action plan updated. And having a regular review with your doctor or asthma nurse is really important. Again, and that can be just the GP or the practice nurse can do that for you, for the child as well. So, but that's something that's, unfortunately in Ireland, we're actually very bad at actually managing asthma. We're not great in that, we're only seeing families and children and adults even whenever they're actually very unwell and having acute exacerbations, and they're not having regular reviews whenever they're actually well, which is really important to do that, because that's when you actually do all the education around that. But it is getting better, and there are things happening, but it's not, unfortunately, it's not the way I'd like to see it, the way it is at the moment. I'd like it to improve a little bit better. So in terms of inhaler technique then, this child here, actually, he has a dry powder device. So he's obviously well able to use a dry powder device. As you can see, he's not using a spacer. But, so again, the right technique will be different for each type of inhaler. And again, there is the asthma techniques, or the asthma society inhaler technique part of our website, where you can go on and have a look to see how to use all the different types of inhalers. and it's mind-boggling because there's so many of them out there. So don't get kind of too caught up in it. But just it's worth looking at just to show you kind of how many different inhalers is actually on the market. And as I say, it's mind-boggling with them all. Good inhaler technique ensures that the correct amount of medication gets into your lungs. And about 85% of people with asthma are actually thought to use their inhaler incorrectly. And I'd say that's fairly accurate, because it's just every time I see somebody, sometimes, you have to re-educate and recheck, and every time there'll be some little thing. And actually they estimate, what's really interesting is if you actually teach somebody to use an inhaler, if I was in the surgery and I was teaching somebody how to use an inhaler, by the time they leave the surgery and walk out, and if you actually check that person 20 minutes later, they'll have learned a bad thing about using their inhaler. They'll be doing something incorrectly. So it's really important that we actually keep checking their inhaler techniques. Having an asthma action plan then is really important. So again, these can be downloaded from the Asthma Society website, but you might see these, and sometimes I know some parents have given them to schools as well, and you may very well see them. But they are a stepwise approach to managing asthma. So you have a green zone, you have the orange zone like it's here, and then you have the red zone. And the red zone is actually whenever the child is really bad and having an acute asthma attack. So again, what's on it is actually very useful. There's a list of medication of when they should be taking it. It'll actually tell you as well about different symptoms, if you're getting worse, and what to watch out for, what to do when your symptoms get worse. It will list your triggers, because on the back of it you can fill in what the trigger factors for the child is. If there's vaccinations being given or anything like that, that can be put in on it. And then it'll tell you again what to do if you're having an acute asthma attack, and the important information about contacting the GP or the A&E department if you need it. So that's the asthma action plan to say. And every person, as an asthma society, we would hope, our ultimate aim is that every person with asthma in Ireland will actually have an asthma action plan. But again, these plans are only any good if they're updated and reviewed on a regular basis also as well. So, but again, they're there, and they're a useful tool to help manage asthma. In terms of, certainly with the list of medication and how they should be, how often they need to be taken, if that's useful as well. So again, this chart, I just wanted to show you this, and this is a question we're getting asked a lot now on the WhatsApp service, the differences between all these different conditions. So what's the difference between asthma, COPD, flus, colds, hay fever, and coronavirus? So again, because like hay fever and coronavirus, there's a lot of symptoms quite similar, again with asthma, some of the symptoms with coronavirus is actually similar as well. So it's quite a good chart, to help differentiate. That's there available for downloading as well. And also I think that's been included in the packs that's been sent out to you also. So
actually, can I just suggest to people, we're more than happy and I'll talk people through what's in the pack in a few minutes that will be sent out to everybody. But what might be useful to people is, aside from us sending it to you in your email, I know obviously most of you will have access to your mobile phone. If you do want to send us a message on the WhatsApp service, Ruth can send on that image as an image on its own to reply to you, and you can save it to your photos and into your favorite file, so that you always have it right there in your phone, right when you need it, if you think you might need it in the classroom. It's a really useful one, and we hear about it all the time, and we can do the same thing with the 5-step route. So if any of you want to do that, and we can blitz through those replies this week to make sure that we've sent out those to you, and that you have them saved on your phone for good or for ill for the next number of months, it might be useful for people. And that's one of the core functions about the WhatsApp service, is that we can send you the materials you need, and that you have them saved on your phone for good. It's quite useful. But I'll leave Ruth continue. Apologies, Ruth.
Yeah, no worries. Yeah, that's one of the most common things I've been sending out actually via WhatsApp. Between that and the 5-step rule, it's a common one that we get asked about, particularly when the hay fever has been so prevalent in the last while as well. So it's a useful one to have. So let's have a chat about then having an asthma attack, and what are the signs and symptoms of an asthma attack. And this is probably one of the things you're kind of rather concerned about, I would imagine. So the important thing, an asthma attack then, right, so a child gets wheezy, they're kind of very wheezy, they're very short of breath, they can't speak to you. That's one of the big signs actually of an asthma attack, is when somebody actually can't speak to you, or if they're answering, that you're only answering you in yeses or nos. You ask them a question and they're answering yeses and nos, or they're answering just in short answers, in single words. That's a sign that things are not always not good. Other things to watch out for then will be blue lips and blue earlobes. They're the other ones as well. So the child is increasingly wheezy, they're coughing a lot, some of them might complain of that chest tightness I was talking about earlier. They can't talk to you. And as I said, they're kind of very pale, or they're kind of the tip of the nose, the earlobes and the lips are going blue. That's not a good sign at all. So what do you do? So this is what we call the 5-step rule, and we can send this to you also as well via WhatsApp. So first thing is sit up and stay down, stay calm, because if the child lies down, they're not going to be able to breathe. They can't open up their lungs. They're getting it hard enough to open up their lungs, but if you lie them down, that's not going to help at all. So it's really important to keep them sitting upright. Encourage them to take slow, steady breaths, and give them one puff of their inhaler, the blue inhaler, through a spacer. Hopefully it's available to you, and you give that every minute for 10 minutes for children aged 6 upwards. And if it's a child under 6, you give up to 6 puffs in 10 minutes. And then what you do is you call 112 or 999. Again, you can also call the GP, and if you're living in areas and like where I am here and in Mayo and etc. in rural areas, you could be waiting an hour, you could be waiting 2 hours for an ambulance. But when you call the ambulance, please make sure you tell them it's for this child is actually having an acute asthma attack and it is an emergency. You know, just don't say you need an ambulance and leave it at that. So be very specific that this is actually an acute asthma attack. And that, as I say, you do that. So while you're waiting for the ambulance, then if the child doesn't improve within 10 minutes, what you do is then you do number 3 again. So you actually give them one puff of their blue inhaler every minute for 10 minutes, or 6 over 10 minutes if they're under the age of 6. So again, if you're sitting there waiting for your ambulance for an hour or 2 hours and the child is not improving, just keep giving this every 20 minutes, at 15, 20 minutes, keep giving this. In this situation, you cannot give enough blue inhaler. You really have to get the blue inhaler into them. And ideally, and the only way to get that in is through a spacer. Right, if the question is, I'm often asked, is that I don't actually have a spacer, we don't have a spacer, the child just has the blue inhaler in their bag or in their lunchbox, and they're doing this. If you actually get, one tip I often give is actually get a coffee cup. You know, a disposable coffee cup, a cardboardy one, and put a slit in the bottom of it, slip the inhaler into that and use that as your spacer, and it works really well. It works just as well as a spacer if you can't get access to a spacer. It's better than not using a spacer. Okay, so but again, the advice will be that we would hopefully hope, and I'm sure Sarah's going to talk about this later, that we would love every school in the country to have a blue inhaler and a spacer for emergency use in their first aid boxes. That is the goal. You know, that's what we want to achieve. But that's, you know, it's really important that this is what we do. So the other thing is don't leave the child on their own. Actually, by the time, sorry, I forgot to say when I was talking about calling the ambulance, is actually make sure you call the parents. Call the GP. If you have a GP nearby you and you know you're going to be waiting for an ambulance for an hour, give the GP a ring. You know, I'm sure you have all the local GP's numbers. Or if you don't have, you should get them and put them, have a file with them on it, and just call them, and call the parents obviously as well. And sometimes maybe the parents might decide, right, I'm going to bring this child to hospital because I'm not going to wait for an ambulance, and you know, that's what they want to do. But again, they need to keep giving the blue inhaler every 20 minutes on the way there. And as I said, extra puffs of the blue inhaler are safe in this situation. You cannot overdo the blue inhaler. No, it's really important that you keep giving it. Now, Emma, or not, Ellen has...
I'm aware of the fact that we've come to 6, right? And we have, I'd say, about 10 questions that people want to deal with. So do you want us to take a few questions now, or do you want to go through a few of the slides that you have in brief and we leave the questions then? Is that the easiest thing to do?
Actually, I think I've only a couple of more slides here. The only thing is, I suppose, we were going to show that video.
Yeah.
So Ellen, would you mind kind of showing the video if you can? And
so we have a 1-minute video, folks, that shows you exactly what to do in the event of a child under the age of 6 having an asthma attack. We'll show that to you now, but I've also just sent everybody a message there on the chat function, which should allow you to have access to the WhatsApp service, and it should tell you exactly what to do. But we'll show the video and we can come back to that after.
Asthma in children can strike at any time. This is an emergency. Act now. Call 999 or 112 at any time if you're worried. Step 1. Gently calm them down. Sit them up straight and do not let them lie down. Step 2. Encourage them to take slow, steady breaths. Step 3. Give them one puff of their reliever inhaler up to 6 times in 10 minutes and use a spacer if available. Step 4. Call 112 or 999 if they're not improving. Step 5. Repeat step 3 if an ambulance hasn't arrived in 10 minutes. Asthma kills one person every week in Ireland. Know the rules to save a life. Visit asthma.ie or call our advice line on 1800 44 54 64.
Great. Thank you, Ellen. I'm just going to go back here. Sorry, Sarah, I was going to go back to this just to finish this. Because this one here, because I have just a graphic here just with the numbers on it. So this is our asthma.ie is our obviously is our website, so you can get loads of information there on that. Our WhatsApp service, that number is there. Now these will all be going out to you anyway near the time. So usually, whenever you message us in and that we get back. Obviously, if you message us at the weekend, it'll be Monday when we get back to you because it is a Monday to Friday service. And just to bear in mind, the WhatsApp service and the advice line services actually they are not actually emergency services. They are for kind of resources and that. And that's the number for it there. And then we actually have our advice line as well that you can call up and speak to, book an appointment to speak to an asthma nurse. So if you're kind of any concerns about maybe getting asthma schools policies in place and that sort of thing, the nurses might be able to advise you there on that. And that's really all I have. And we'll just start maybe answer a few questions, Sarah, whenever.
Yeah, perfect. I might just reiterate to people, if that's okay. So I'll just explain to you a little bit about the pack. So Ellen, who works with us, who's been brilliant about emailing you all and arranging the webinar this evening, Ellen is working on the asthma pack that's going out to all schools who are participating in the Safe Schools programme. But we are sending it to any person who is attending this webinar, or if anybody is logging in and is looking at this retrospectively, if you get in touch with us in the office, we'll send you out the list of resources. It includes the link to any posters to print for your school, the link to the asthma attack video for a child under 6 or for children over 6 or adults. We also have a video in there which just gives you a little bit of detail about what the symptoms look or feel like, kind of representing it from a patient's point of view, so that if you hear a child talking about their asthma, hopefully it would help you recognize, gosh, this is an asthma attack and I should know to take the proper actions. We also have a link to some really nice lesson plans specifically about asthma and clean air, which are a really good way to educate the whole class and to keep everybody safe by other children understanding more about their asthma. A link to our kids corner, and we have a really fantastic gorgeous booklet with loads of quizzes and puzzles and kind of fun things around asthma, so that you can kind of kickstart a conversation in your classroom to make sure that any child with asthma feels that it feels normal and accepted, that you remove any stigma around asthma, and that it's treated as a normal part of growing up, that some children will have asthma and that their little friends at school will know exactly what to do around it. So we'll send you out that pack afterwards, but just to reiterate, I've sent everybody on in the chat message there the link to the WhatsApp number, and essentially how that works is you send either Ruth or Samantha, depending on who's on call on a day, a message on our WhatsApp messaging service. So you literally just send a text on WhatsApp to the number that I've given you and the one that was on screen a moment ago, and either Ruth or Samantha will reply hopefully within a number of hours. Normally they're very prompt, and they can send you on any of the resources that we've mentioned so that you can save them down into your phone. But also if you need any guidance or advice about a specific child with asthma in your class that you have concerns about, or about what to do on a classroom level, they can give you some guidance or advice. And the second piece we've included there is about the advice line call. So we have a team of nurses who support us on advice line. They're all specialists in respiratory and in asthma. They know asthma backwards and forwards. They're absolutely amazing. And what happens is you phone into us, and then Ellen, who you were dealing with earlier, arranges an appointment with the nurse over the telephone, so that if you have a concern, in August heading into September, with going back to school, the kids get sick, they get asthma, and you kind of want to do a little bit of a refresher for yourself, we can arrange a nurse appointment for you at that time of the year, so that you feel a bit guided and you have whatever support you have, so that you don't have to worry about maybe any particular kids in your class with asthma, and that you kind of know that you have it all straight in the back of your mind. Feel free to phone us. That's what the service is for. But what I might do is touch on some of the questions. So we had 2 questions relating to spacers. I think the first one is answered, Ruth, which was, is it important to use a spacer? So you talked about drug distribution being much, much better if you're using a spacer. So it is important. But Nicola also asked us how often to replace a spacer.
Okay, it depends on the type of the spacer. If it's the bigger volumatic, they need to be changed every 6 months. If it's the aero chamber, that one there, the yellow one that we had with the mask on it there, it's every 2 years. So it depends on the spacer.
Okay. Somebody asked where we could get a peak flow meter. That was an anonymous question.
Yeah.
Just to let you know, we used to sell those on the Asthma Society website. At the moment, we have no access to our offices because of COVID. So our shop isn't functioning because we don't have anybody in the office who can sit there and post stuff out as normal. So if you do need a peak flow meter, you can go into your local pharmacy. You can tell them that you want one. They may have them in stock, or if not, they can order them for you. Would that be correct, Ruth?
Yeah, that's it. Yeah, your local pharmacy will have one, and there's about 2 or 3 different ones. It really doesn't matter which one you have.
We consider them to be absolutely brilliant piece of the toolkit for people getting in control of their asthma and for recognizing when their asthma is getting worse. If somebody has a peak flow meter, often we really think that's the back broken of asthma management in their heads, because they actually understand the relationship between their lungs functioning well and their triggers and their asthma management. We have had a question here from Mary, who says, how would an inhaler work in relation to COVID? Ruth, do you want to deal with that question?
Yeah, now I guess obviously it's better that every child has their own individual inhaler. Yes, that would be the normal thing that we would kind of encourage, parents to send a reliever inhaler with the child in a lunchbox to the school, and they leave it on their desk. I've often prescribed, individual inhalers for children to bring, and it's left in school, all the time, and then they have their other ones at home, or they might have a second one at home. So obviously it's better that each child does use their own inhaler. However, in an acute asthma situation, that kind of is overruled, to be honest with you, because acute asthma attack is life-threatening, and that's what the acute asthma and how you manage that, it actually kicks into play. So again, if you have
Ruth, maybe just so you understood or heard the question properly, the person was asking in relation to the inhaler with COVID, not with an asthma attack.
I know. Yeah, there's no problem with COVID and children using their inhalers. No, they're not considered what we would call a high aerosol generating procedure. They're fine to use them. But I suppose what I was trying to explain there was that do you mean, is it a child using another child's inhaler? That's what you would be concerned about, or is it because
I think my interpretation of what Mary was asking us was, like, would an inhaler be good if a child had COVID, that you would give them an inhaler to use? But perhaps I have misconstrued Mary's question. Maybe what we might do is deal with the others. Mary, if you're online there and you want to clarify, will you pop us a message just so that we'll make sure we're properly answering your question? Fiona said, should a child with asthma related to allergies carry an EpiPen as well as an inhaler?
If it's been prescribed by the consultant, yes, and EpiPens will be prescribed by a consultant dealing with that child's allergy. So, but generally, for the majority of children, no, because EpiPens are more to do with food allergy, etc. So, if the child has been diagnosed with a food allergy by a consultant and they need to have an EpiPen, then yes, they should be carrying their EpiPen. But for general asthmatic children, no.
Okay. Somebody had asked you, which I asked earlier on, about somebody being out in the rain, a child being out in the rain, would it trigger asthma symptoms? But somebody else has queried, if they were out in the rain and they were then sitting in damp clothes, especially with the windows open, is it possible that might trigger asthma symptoms?
Well, it'll trigger them actually to get a cold or a flu out of it. That's what they'll get, which then in turn, that might actually trigger their asthma symptoms. So it's more the virus actually. The actual fact that there's a virus in their airways, like an ordinary cold or flu virus, that actually can make the asthma worse. So yes, but I mean, they're out in the school time in the yard and they get wet and they come in and sit down, that's not going to give them asthma symptoms.
Okay, we had an unusual one here, Ruth, that I hadn't come across before, which was that one of the questioners that queried that they had a child in the class in the past whose back used to get very itchy all over, and that she knew she had to take her inhaler when her back began to get itchy. Is this a common indication of an asthma attack?
It's not a common one, but it could be for that particular child for whatever reason that might be. So again, if the parents are telling you that this is what they know that their child, this happens with their child beforehand, and it's a warning sign for them, I would pay heed to it. But it would not be a common a sign of an acute asthma attack.
Fiona is asking, will a child with asthma always have a brown and a blue inhaler, or is there ever an occasion where they have one or the other?
No, most children will all have brown inhalers, because that's what actually manages their asthma, controls their asthma. So yeah, well, the answer to the first part of the question is yes, they will always have a brown and a blue, but it'll be both. Occasionally you will see children just with a blue inhaler on their own, but I would actually be questioning why are they just using a blue inhaler, to be honest with you, because they really should be on a brown inhaler anyway.
Yeah, I think maybe just to, from what we would hear, I think traditionally often children might have been given a brown inhaler or a blue inhaler on its own, but it would be much more common now for a GP to be prescribing the two, because that controller piece is considered so much more important now than it was historically in the past. Breach is asking, should we be asking children to bring in a spacer to use with their inhaler? And what if they tell us, as in parents, that the child doesn't need it?
If they're having one of those traditional squirty inhalers, as I to call them, they should be using a spacer with it. And there's, you know, if parents are telling you that they don't need it, they do need it. That's the bottom line of it. Okay, I'm sorry, but that's the way it is. And, you know, that's what we need, the message we need to be getting out there, that should be using they should be using spacers with their ordinary inhalers. Now, if they have a dry powder inhaler, that's a different story. Okay, so that's a different type of inhaler. But if they have one of the ordinary traditional meter dose inhalers, they should be using a spacer with it.
Okay, I mean, Breach, I think maybe our suggestion there is, you know, we're very happy whether it's through the WhatsApp service or whether it's through the advice line service for one of the nurses to talk a parent through that. So if you want to say that you've done a session with us and that we really strongly recommend it, we think it makes a huge difference, or that the clinical research shows that it makes a huge difference to a child getting all of that access to their medication. And for example, you wouldn't be handed a tablet and break it in half and only take half the tablet normally, which is essentially what often people are doing when their inhaler technique is quite poor. They're only actually getting half the dose of the medication. But if you want to suggest to that parent that they give us a call, either for a nurse appointment or that they do the chat there with Ruth on the WhatsApp messaging service, we're happy to facilitate that. And that's really what we're here for, is to make those conversations as easy as possible for you guys to do a little bit of a nudge or a prompt, and we can weigh in from there and support any patients. Ethna has asked, what is the initial first response to a child having an asthma attack in the classroom? I mean, I think, Ethna, what we'd be saying and what Ruth is trying to communicate there to you is the initial first response is the 5-step rule. That's the gold book, that's the guidebook, that's the Bible, that's the golden rule in terms of what happens if somebody has an asthma attack. But Ruth, is there something you want to reiterate there for Ethna?
No, the first aid, Ethna, that's exactly it. The 5-step rule is how you manage it. You know, that's it.
Perfect. Somebody has asked me if we have resources Oscuelga. We don't actually have resources Oscuelga at the moment, but we ran a really major project last year towards the end of the year, whereby we worked with Pave Point, with a Roma migration unit, and with the services offering education and health supports to people seeking international assistance, or, you know, traditionally what we would call refugees. So we actually have created videos about asthma management in 8 different languages. If you go to our YouTube channel, you'll find those there. So if you have any children or parents of children in your class who have language challenges around any of those particular languages that we cover, those are all available there. I'll get Ellen to include it in the pack, the link to where you'll find all of those. They can be really good if you're trying to help a parent who maybe doesn't find English as easy to manage. I can just, I'm just sorry, somebody's just queried there about the WhatsApp number. I've sent that out, but we'll include that in the pack as well to make sure that people get it. Esther has just queried about the dosage. So she's mentioning that some blue inhalers are 50 mils and others are 100 mils, and what should the school have? Esther, a few people have asked us the question, as in, how do you go about getting an emergency inhaler in your school? And really what we need to tell you is that the reason we're running the Safe Schools program is so that you can get an emergency inhaler. And the big logjam and problem that we would experience is you are only entitled to register as an organisation who can get an emergency inhaler in your own right, separate to having a prescription for a specific child, if you have done this 8-hour pre-hospital emergency first aid training. And so that's why we have provided the funding for 39 schools to get that training, because that means that 39 schools will then be able to register for the inhaler. We'll provide that as support once your school has done the training to make sure that you can get it. If you're participating as a school that hasn't been accepted with a place on the Safe Schools program, obviously with very limited funding this year, we're hoping to run it later on again this year so that we can get many more schools into that system. Or it may be the case that you should flag it with your principal to see if they would have funding to pay for this 1 day of first aid training, which means that any of your staff members are ready to deal with first aid emergencies, but also are primed and ready to deal with an asthma attack. So that's something to bear in mind. But what you can do is, if you're not sure, you can email us. Ellen will take the details and we'll respond with the 2 or 3 page explainer about how to register for the inhaler. Unfortunately, it's not the easiest process, so that's why we're on hand to give you a hand with it. We think it's really important, and we will do our best to make sure that it's as easy as possible for any of you. But obviously, if you have been accepted in the Safe Schools programme, that will make that much easier for any of you to get through the mix and to make sure you have that correct training on board according to the legislation. And just to say, we have been feeding back to Ministers of Education subsequently that should be as easy as possible, that training and the administering and the registering to get the inhaler, whereas we feel it's much clunkier and more difficult and administrative than it should be. And that's something that we're trying to get government to change so that we can just get as many schools to be asthma safe as possible. I just have another query there about the emergency inhaler. So that's coming from Brian. So Brian, I've just explained that. Should all children with asthma bring their inhaler and spacer to school? What if the parent says they only need it before school and they're fine for the day? Ruth, do you want to take that one?
Yeah, they should. All children should actually bring their blue inhaler to school with their spacer for an emergency use. And as I said, I would regularly recommend actually parents, I've often said to parents that just get a spare inhaler and leave it in school all the time. And then you haven't to be thinking about sending it with them every single week. But their regular medication, their controller medication normally is only taken morning and evening. So they don't need to be bringing that because it's taken before they go to school in the morning, taken again, before they go to bed. So again, as I say, the blue inhaler is the important one, and they may never, hopefully they will never need to use it in school, but it's important that they have it there anyway.
Thanks. We do have a question from an anonymous attendee, so I don't have that person's first name, and they've indicated that their daughter has asthma but hasn't had symptoms in over a year. They've been hasn't used their medication in over a year, keeping up with peers and stuff like that. And essentially this person is asking for some guidance from us over this webinar in terms of whether they should continue using the brown inhaler or the preventer inhaler. Can I just suggest that that person sends a message to Ruth via the WhatsApp messaging service and or gives us a call in the morning, and Ellen will arrange an appointment with one of the advice line nurses for you. We're more than happy to guide you through maybe what some sensible next steps might be in terms of your daughter's care, but I don't necessarily want to do it over the webinar because we wouldn't have enough information back and forth to give you the best advice. That's better done one-to-one if that's okay. I have a question here, Ruth, from Lisa. Thank you, Lisa, asking if we can use a child's inhaler in an emergency, which is definitely actually something we wanted to touch on because I know Ruth had that on her list of questions she wanted to answer. Ruth, are you okay to take that one?
Yeah, exactly. Sorry, I just didn't get the beginning of that question, Sarah.
Apologies. Lisa is asking, is it okay to use another child's inhaler in an emergency?
Yes, in an emergency situation.
And actually,
in an emergency situation, yes. A blue inhaler is a blue inhaler, regardless of whether it's that child or somebody else's child. I would definitely give it. If that child is sitting there gasping away in front of you and can't get their breath and is struggling for breath and are going blue in the lips, they need the blue inhaler there and then. So yes, I would use another child's inhaler in that situation, without a doubt.
I mean, I suppose just to be really clear on the messaging, our absolute fear is that a child dies of asthma and that they die of asthma at school where you don't have enough information or support to help that child. So we want to do everything we can to avoid that. Obviously, the optimal here is that the child knows about their asthma and understands it. You've been fully briefed, that you have an asthma policy in the school, that you have an asthma register, that you know where their medication is in case of emergency, and that you also have medication available to you, which is separate in case they can't find it. But really what we also want is to boost your confidence so that you know if you have a sick child in front of you, you believe that they need intervention, that you feel comfortable enough to say, okay, it's not perfect that they take another child's inhaler, but that's better than the child really gasping and being very seriously short of breath and potentially experiencing a life-threatening asthma attack. So that's really important. But if you're concerned about that, send us a message on the WhatsApp service or set up a call and give us a call, and we'll set up a nurse appointment for you. I mean, really, we feel that teachers are really under-resourced and under-protected in terms of needing help to manage these scenarios, and we want to do whatever we can to help and support you, and we think that's really important. I have a few questions here about the training. So Norma is asking, does the whole school need to do the first aid training? Our school has just done CPR, defib, first aid with 80% of staff. So I think what happens in that case, Norma, is if it's this very specific kind of course, which is the pre-hospital emergency care training, once you can tick that and you can certify that the school has done it, then you can register to have the inhaler. But we can give you a hand if you're not sure that it's the right level of training. You can email us and query it with us, and we'll send you on the piece that we've done up, which gives you support about how to apply for the inhaler. Brian has mentioned that this is brilliant information. Thanks, Brian. We're delighted to hear that. And it's a pity that governments don't see the importance of this education and awareness. Totally with you, Brian. It's a source of disappointment to me that you're not better protected with the scenarios you might face, and that children aren't better protected. And I suppose one of the comments that we did have in advance of this was from a particular teacher who said to us that they were concerned about the fact that they live in rural County Mayo. They're in a small two-teacher school. They're more than an hour from the asthma or from the for a trip for the ambulance to get to them and what to do. And so this is one of the things that we wanted to flag with you, is like, dealing with this quickly and efficiently is better than dealing with it either perfectly or following the full list of every procedure known to man. So please feel free to respond to an asthma emergency, because it's very important, and that really what we want to do is have a very good and effective conversation with government to say every school should have an asthma pack, every school should have teachers who are trained in it, every school should have a spacer and an emergency inhaler on board. For example, that's one of the cases in one of the states in Australia. Every single school is not mandated to open until they have those pieces in place every single day, and that's something that we have been I suppose trying to talk about at the highest levels of education policy in Ireland. And then we just have a few queries then. Somebody has queried, and they asked us in advance about explaining stridor breathing. Ruth, can you take that one?
Yeah, stridor is actually whenever they're breathing in. Okay, so you actually hear this kind of, the child is laboured, that they actually can't get the breath in, whereas with wheezing and asthma, it's breathing out. Okay, and usually with stridor, it's a lot louder. It's more, as I say, it's far noisier. It's often a sign of croup. Kind of that croupy thing. If any of you ever have children that have had croup, you know all about the stridor. And it's usually more to do higher up in the larynx area as well. So again, that child shouldn't really be at school. They should be at home if they're having difficulty with stridor.
Okay, folks, I don't want to keep people very late because we've already run well over. I think I've gotten to most of the questions. Just to clarify, some person had asked us in advance about the 5-step rule poster. Again, we can't post those out because we don't have access to the office at the moment. We'll include them in the pack, and when we reopen the office, fingers crossed, hopefully September/October, whenever the government restrictions allow, we'll be sending out school packs again, and we'll hopefully be able to send those out to you if we can get the prerequisite funding to do that. The other thing I might just say to you is, if you've asked us a question and we haven't been able to get to it this evening, please will you send that question to either Ruth or Samantha on the WhatsApp messaging service in the morning. So that's where you send a message on WhatsApp to 086 059 0132, or you can give Ellen in the office a call in the morning on the asthma advice line, and that's on 1-800 44 54 64. So that's 1-800 44 54 64, and Ella will arrange for a callback appointment with you for the nurse, normally within about 24 hours. If things are a bit busy after this evening, it might take us a few days to get an appointment for you, but we can talk you through asthma management in the classroom, any specific kids that you have a concern about, that you want to feel that you're kind of beefed up a little bit and you kind of know enough. And again, if you don't feel like you want to do that right now, but you want to do it in August in advance of the return to school, please feel free to do that. That's what the service is for. And the more we equip you to know about asthma, in terms of your kids, the more asthma ambassadors and kind of champions of asthma and good asthma management we have out there. So just to say thank you so much for dialing in on a beautiful sunny Monday evening. We really appreciate it. If we haven't been able to answer your question, would you please pop us a message either by email onto Ruth on the WhatsApp service tomorrow, or onto us via Ellen in the morning on the advice line. And thank you so much for your time, everybody, for your thought, your consideration, and for taking this seriously. I mean, it's very nourishing to us to see that this matters to you and that you're doing your best on it as well. Thank you so much.